This is Rural Health Leadership Radio.
Episode 184, a conversation with Tracy Conroy, CEO, Valerie Rourke, Director of Cardiopulmonary Services, and Connie Wilson in Cardiac Rehab, all with the Daviess Community Hospital.
Don't let fear of the unknown keep you from seeking the care and the treatment and talking to your physician about what you can do to improve your lifestyle.
Welcome to the Rural Health Leadership Radio with your host, Dr. Bill Oxier. Each week, Dr. Oxier has a conversation with a different rural health leader to discuss what's working and what's not working in rural health, along with other topics of interest to rural health leaders. Rural Health Leadership Radio's goal is to improve health in rural America by providing a simple, no-cost means to share information and connect rural health leaders from around the country. And now, here's Dr. Oxier with today's guest.
Hi, everybody. I am your host, Dr. Bill Oxier, and welcome to the Rural Health Leadership Radio podcast. Quality, operations, finance, and leadership. What rural health leader wouldn't want to improve on any of those? That's why I am introducing today the Quality, Operations, and Financial Improvement Leadership Project for rural hospitals and clinics. Our goal is to assist rural health leaders leading to not only survive, but to thrive. And it can be done. We know because we've collaborated with rural health leaders to do just that. Now, our group is looking to recruit 2 new rural health hospitals or clinics to participate in this program. So if you're interested, send me an email to bill@billoxier.com. Today, I'm excited for our guests to share information to assist rural health leaders with best practices as it relates to chronic disease management, COPD in particular. Now, this interview took place a few months ago as episode 6 in a 7-episode series that the National Rural Health Resource Center put together for chronic disease management. And I want to thank them for allowing me to be a part of that and for making today's episode possible. So, on to today's guest. Today, we're having a conversation with Tracy Conroy, CEO, Valerie Rourke, Director of Cardiopulmonary Services, and Connie Wilson in Cardiac Rehab. They're all with Daviess Community Hospital in Washington, Indiana. Welcome, Tracy, Valerie, and Connie to the COPD podcast.
Thanks, Bill. Thank you.
Thank you.
So let's start out with learning a little bit about who each of you are. Can you tell us about yourself? Let's start with you, Tracy. Who is Tracy Conroy? What's your story?
Well, I think my story is a little bit different than the majority of CEOs. I've been here at Daviess Community Hospital for a little over 2 years, and my background is a registered nurse. So I come from a little bit different perspective from most CEOs. They're very financially driven. And I think my clinical background, it gives me a better understanding and a better relationship with the employees of what it takes to deliver quality, safe, service-oriented care. And I think it just helps me build a better connection with the staff. But of course, that's coming from a clinical person, and I'm sure financial CEOs have a much different opinion. I've been in healthcare for over 25 years in a variety of different positions, both long-term care, acute care, outpatient clinics, and physician practice management.
Excellent. I'm sure that clinical experience does pay off, and but you're right. You know, everybody comes with their worldview that they bring, whether it's financial or clinical. But thanks for sharing that with us, Tracy. How about you, Valerie? Who's Valerie Rourke? What's your story?
I am a registered respiratory therapist with 39 years of experience in the field. I have been here at Daviess Community Hospital for 30 years as director. I started out in a neighboring hospital and got some leadership experience there, and then came over here. I live about halfway in between the two, so it makes it convenient to pick and choose which direction I want to go. I'm the mother of 3 children and the Mimi of 3 beautiful grandsons. I have 12 employees here that I think are the most outstanding and work-hardy people that you could ever ask for.
Thank you.
I think they're very easy to manage, very productive, and they don't take a lot of my time in getting to work and getting the job done right the first time.
Yeah, so is it easier being a director or a Mimi?
It's easier being a Mimi anytime.
Yeah, okay. Thanks for sharing that with us, Valerie. And last but not least, Connie. Who is Connie Wilson? What's your story?
Well, Connie Wilson has been a registered nurse for 34 years. I spent my first 6 years in intensive care type settings. And then I found a cardiac rehab position, which I really felt my calling to that. And after I started doing cardiac rehab, I discovered that there was a world of pulmonary rehab out there. So developed a pulmonary rehab program at the hospital that I was at before this, and then have been doing the pulmonary rehab since it started here. I have a passion for learning, and I have a passion for teaching, and I don't know which one I love more.
Okay.
Yes, you'll find out I continually go to school. So, helping people become healthy is what I really am driven to do. And so through the programs that I offer here, that's one of the things I can do is teach people how to deal with their chronic conditions. I have 2 children, and I am a Gigi to one grandson who's 2.5. And that has been a very wonderful journey there. And I am married and have been with my husband for almost 33 years.
Awesome.
So, thanks so much.
Yes, thank you. Lots of experience here, and I just became a grandpa for the first time 3 months ago, so I'm still getting used to that grandparent role. So I thank you for adding that into telling us about yourselves. So today we're here to talk about COPD. Why are you here talking with us today about COPD? I'll gear that question towards Valerie and Connie, whoever wants to go first.
This is Valerie talking. COPD is a diagnosis that's been around since I've been in the respiratory profession, and it's a diagnosis that's going to be here long after I'm out of the profession. It is not going away because so many different factors cause COPD, and it doesn't really have a cure. You treat your symptoms and do a lot of cheerleading for these patients. But it's going to be here for years to come. And air pollution, smoking, and the things that contribute to having COPD aren't going away either.
Yeah, and I'd like to add to that, I'm here because I know that pulmonary rehab plays a critical role in helping patients with COPD. It's something that a lot of people don't know about. So I think that, getting that information out there to the general public, to other healthcare providers, we find that even within our facility that some people don't know what pulmonary rehab is or how it can benefit the patients that have COPD.
Yeah, that's all important stuff. I mean, I know when I was doing research and preparation for doing this podcast series, I was shocked to find out that 25% of COPD patients are non-smokers. I always thought that it was directly correlated, but so there's still plenty to learn about that. So, Connie, since you like to learn and teach, I think there's plenty of opportunity for you here in that regard.
No doubt.
So why did Daviess Community Hospital decide to start a pulmonary rehab program?
I had been approached a number of times we'd started an inpatient rehab program, and they were discharging folks there who needed pulmonary rehab. And the more they discharged that needed it, the more times I was being called or approached. Have you ever thought about this? Have you ever thought about this? And the last time I had formally looked at it was 2001, and the decision had been made we didn't want to venture into it. And we hadn't started, I don't think, our inpatient rehab then. We were looking to merge with physical therapy then and do it. So the more they asked, and then when our med-surg floor began to get the discharge planners saying, hey, you need to start this. We took another look, and Connie came on board at the time and had started pulmonary rehab elsewhere, and it just made sense. We had the equipment that we were already using for cardiac rehab, and you didn't really need to buy anything else. So we had the personnel, we had the equipment, and thought, why not? Now's the time.
So, Connie, what have you discovered over the last 3 years since you started that program?
Well, the one thing that I have realized is that we need to spend more time getting the physician buy-in. So we have a large population of primary care physicians that we pull from. And, when you can get them knowing what your program is and get them referring the patients in, because I think when it comes from the doctors, the patients are more likely to do it. And most of the patients that have COPD, they don't really know that there is anything out there that's going to help them, because they've seen mom and dad and everybody die of it, and they just look at it as a hopeless deterioration, and that they're going to live their life the same way.
Yeah, and my understanding is that if you can get an early diagnosis, that doesn't have to be the case. Is that correct? Very
true. If we can get them in there when they're actually first starting to have symptoms, we can actually keep them at a very functional level. And even if they are having significant symptoms, we can get some of that reversed to where they can get back to doing some of the things that they like to do again.
So I'll direct this question to Valerie or Connie, I guess, whoever wants to take a shot at it. Can you talk about what was involved in getting the program up and running?
I think the biggest piece was finding the person that was most passionate and had done it before. Then that was Connie. When she came to interview, our cardiac rehab nurse was retiring, and she'd been here a number of years. And the timing was right. We had the right person with the knowledge base behind it. And we hired her in and said, let's do this. And with her knowledge, she jumped right in, and we got some policies in place. And we took off with that program, and Connie can kind of add to what she did with that.
Yeah, the infrastructure was already here because, I had started, again, a pulmonary rehab program before, and it was incorporated with my cardiac rehab program.
Okay.
So I knew how to kind of put the two together to marry that, so that we didn't really need a whole lot. We needed to get just the policy and procedures. And then, I kept telling Val, you send me patients, we can do pulmonary rehab. And so that's kind of how it all worked.
Okay. All right. Well, it sounds like they did find the right person. Sounds like you grabbed the bull by the horns and took it from there. If a hospital does have a cardiac rehab program, do they pretty much have the equipment they need to start a pulmonary rehab program?
Yeah, the only other thing you have to have would just be to be able to monitor oximetry, which, most of your respiratory departments are going to have that. And even if you don't have cardiac rehab, if you have a strong physical therapy program, you could also combine it with something like that, as long as the exercise equipment is there. So that, you just got to kind of think about what is there and what is available.
Gotcha. So it sounds like you might be the key ingredient to all this, Connie. We need to find more Connies in the world for hospitals that want to start these programs.
Always happy to help anybody that needs that too. So.
Okay. Since I'm talking about you, Connie, let me ask you another question. Can you talk about the fears that your patients experience? I think that's probably a bigger deal than at least what I might think about.
Yeah, if you think about struggling for breath every single day of your life, because that's the way a lot of these patients are, that's a scary thing. And then when I call them up and say, hey, your doctor wants you to come to pulmonary rehab and exercise, and they can't even walk across the floor without getting short of breath, they kind of think I'm a little bit crazy to begin with. So I have to assure them that, we're not going to do anything that they're not able to do, and that walking is the most difficult thing that they will do. So if they need to come in a wheelchair, I've got plenty of different kinds of exercise equipment that we can utilize to start building them up and increasing their stamina, so then they'll be able to walk again.
Very interesting. Yeah, thanks for sharing that with us. Now, you've got 3 years under your belt with the pulmonary rehab program. What do you know now that you wish you would have known when you started that program 3 years ago?
Well, I'll go back to getting the physicians more involved in it.
Okay.
And, I'll take some of the blame for that in the fact that, we just have not really found that huge connection and that huge champion for it besides our pulmonologist. And some of these patients don't see pulmonologists in this rural community. So, I need to do more outreach for the primary care physicians in the area to let them know what I can offer their patients.
Yeah, you'd think they'd be on board with that, but what something that I've learned in this process as well is that a lot of primary care physicians aren't able to connect the dots to understand all of this. Am I interpreting that correctly, or is there something more there?
Well, I don't think it's so much that as it is the fact that when a patient goes in with COPD, the doctors are more thinking about, okay, well, how do I get them through their crisis? So they're thinking more medications and things along those lines.
Gotcha.
And so pulmonary rehab, unless I really get out there and give them the information, sometimes they don't really know what I can do for their patients.
Got it.
I think the other part that you don't think about is educating your inpatient nurses or your when they're ready to discharge their respiratory patients. If they've got some of these COPD patients up there that they've treated for 2 or 3 days, and they identify them as a candidate maybe for pulmonary rehab, they can always put the bug in the physician's ear upon discharge and say, hey, you might want to send them through the pulmonary rehab program.
Yeah,
we certainly didn't get on that in the beginning.
Mm-hmm.
And even today, the respiratory therapists aren't always good about making that connection, and we need to do better because we can feed our own program that way if we would do that.
Absolutely. So there's lots of opportunities for education to share with other professionals what all you can do for the patients there. Very interesting. Tracy, I haven't asked you any questions for a while, so let me give you a question. Can you talk about the financial impact of the program?
Yes. I don't think any organization probably starts the program because of the profit margin. I think we all know that reimbursement for rehab is very low. But luckily, our expenses are low. We can combine resources, and it definitely it allows us to manage the program at a pretty neutral point, break even. So I think that's important. The reason why I think organizations should do it and why we do it, it's to provide that service for the community. These patients don't have any other opportunity, if you will, and it allows them to reach the maximum function of life, to be able to reach their maximum ability. And I think it also, there are definitely benefits to the hospital. Especially, avoiding readmissions in the ER. Many of these patients, what we call frequent flyers in the ED, not able to breathe, having difficulties. And it definitely reduces the readmissions to your hospital. And again, I think it's just the right service to provide for the community. And yes, it's not a big profit margin, but it certainly helps everyone, including the institution, but more importantly, the residents in the community.
Yes, thank you for sharing that perspective. So, COPD, it's like we were talking about earlier, it's scary in a lot of different ways. What scares you the most about the future of COPD care? Connie, let's start with you.
Well, I think the thing that I see with the patients that I deal with on a daily basis is the expense of the medications for this chronic condition. And there's some great new meds that are coming out, but a lot of them are not covered under their insurance plans. And so they might get, some samples and they might be doing really well on it, but then when the insurance doesn't pay for it, then they can't afford it. And then they have to go back to an inferior product. And so I think the expenses that these patients have to put out is the scariest thing, because I think there's a lot of resources out there, but patients can't afford to access them.
Yeah, that's definitely scary. What about you, Valerie? What scares you the most about the future of COPD care?
I agree with Connie on the cost of care.
Yes.
Not only in the medication, as far as the breathing medication, but oxygen. A lot of these, as they progress through the disease, end up on some kind of oxygen therapy, and the cost of that is being passed on to the patient because the home care companies are not being reimbursed like they used to. And we're also seeing that the main cause of COP in the U.S. is tobacco smoke, and that women who smoke get COPD at younger ages than men. And that is kind of scary to think that.
Yeah, it's very concerning. So thank you for sharing that. What about you, Tracy? What scares you the most about the future of COPD care?
Well, I think both what Valerie and Connie said, but looking at it from maybe a little bit different perspective as far as the reimbursement, yes, it's low, but I think what scares me is that communities, especially small rural hospitals, won't look at starting a program or continuing a program because of reimbursement. It may be a first service that's cut because there isn't a profit, and I just think that would be very detrimental to the patient and ultimately to the hospital because, like we talked, the readmission. So just want to make sure the people that need the access have the access.
Yes, absolutely. Thank you for sharing that. So what gives you hope? Connie, let's start with you on that one.
Well, I think having programs like pulmonary rehab is what gives me hope, because I know that the patients that come into pulmonary rehab and that really embrace what we teach in there, that it's life-changing for them. So we can give them back that quality of life that they thought they might not have, which means maybe they'll enjoy being able to spend time with their families and their grandkids rather than just sitting in a chair and being short of breath.
Yes, that is good hope. What about you, Valerie? What gives you hope?
There are resources available out there. There are organizations, raising money, doing research, trying to help these patients to offset some of their out-of-pocket costs, looking for better meds, things like that. There's hope on the horizon that these people will live a better quality of life as they progress through the phases of COPD.
Yes, that does give hope, doesn't it? And Tracy, what about you? What gives you hope?
Well, I think it's very obvious from listening to both Connie and Valerie how passionate they are about the program. And just having people, clinical staff, like the two of them, available to impact the patients that we serve on a daily basis. So that definitely gives me hope. And I also think our board is very, very supportive of programs such as this. Again, you may not turn a lot of profit, but they look at the service that's needed for the community. And I think that gives me hope.
Absolutely. I can understand why you said that because I can hear from Valerie and Connie the amount that they care about this, the passion that they have, and without the support of your board, none of this would be possible, I suppose. But thank you for sharing that. It's hard to believe time has kind of flown by here. We've covered quite a bit of territory talking about COPD and Daviess Community Hospital. If our listeners only take one thing away from our conversation today, what should that be? What would you say, Connie?
I would say don't be afraid to think outside of the box. Look at the resources that you have available in your facility, and then put the needs of the patients to the forefront, because that's what we're here for.
Thank you. How about you, Valerie? What's the one thing you think listeners should take away from our conversation today?
Don't just think of your respiratory therapists as treatment jockeys that just can go to your inpatient unit and push bronchodilators and that kind of therapy. Look at other programs that you can utilize them in, because you'll find some therapists that really, really has a desire to work in something just a little bit different, and turn them loose on a project like this and just see what happens.
Thank you, Valerie. And Tracy, we'll give you the final word. If our listeners only take one thing away from our conversation today, what should that be?
I think it should be, don't let fear of, if I'm the patient, don't let fear of the unknown keep you from seeking the care and the treatment and talking to your physician about what you can do to improve your lifestyle. But then if I'm on the other side, don't let fear, if I'm an organization, don't let fear keep you from implementing a program like this because of cost and reimbursement. because I think it's a win-win for both patients, community, organizations.
Connie Wilson in the Cardiac Rehab Services, Valerie Rourke, Director of Cardiopulmonary Services, and Tracy Conroy, CEO, all with Daviess Community Hospital in Washington, Indiana. Thank you so much for joining us here today on the COPD podcast.
Thank you, Bill.
And thank you all for listening. If you enjoyed today's episode, please go to iTunes, Stitcher, Google Play, whatever your favorite podcast app might be, and subscribe to Rural Health Leadership Radio. And to continue the conversation of leadership in rural health, you can also join our LinkedIn group called Rural Health Leadership Radio. And while you're on Facebook today, check out our Facebook page. And we love likes. Until next week, let's keep working to improve rural health, one conversation at a time.
If you would like to connect with today's guest, please send an email with your contact information to bill@billoxier.com. If you would like to be a guest or suggest someone else as a guest, have a question you would like to ask, or simply want to contact Rural Health Leadership Radio, please use that same email address, bill@billoxier.com. That's BILL@BILLAUXIER.com. You can also visit our website at www.rhlradio.com.
And we'd ask that you please support our sponsor, the Dynamic Leadership Academy for Rural Health. The Dynamic Leadership Academy for Rural Health's mission is to improve rural health, one leader at a time.